First of all, selamat pagi, namaskaram, and good morning to all of you all. Okay, regarding menopause, I'll just summarize the common mistakes that we doctors make and what we don't pay attention to. It's not just menopause, but all phases of life, pre and post menopausal, are important. Women's health in the pre-menopausal part of their life determines how soon they go into menopausal state and whether they face more complications. Okay. Number two is that menopause is just not about estrogen and progesterone. It's also about another very important hormone, testosterone, which also comes mostly from the ovaries. So once menopause, when there is decline or loss of estrogen, progesterone, it is always associated with testosterone deficiency as well. However, there are other hormones associated with aging that also determines the quality of life for postmenopausal women. That would be especially the thyroid hormone and the adrenal hormones, besides other hormones like growth hormones. Now, the thyroid and adrenal hormones decline can be much earlier than menopause. So it's good to recognize that a loss of just not estrogen, progesterone, but the other hormones, testosterone, thyroid, DHEA, and cortisol, they all matter. And deficiency predisposes women to premature aging and diseases. So it's just not about estrogen and progesterone. The other point I would like to make here is that please pay attention to xenoestrogens, that are synthetic estrogens that get into our body that can also have different presentations. Now, why hormones are important? Because we need to realize that hormones act as molecular messengers. So every metabolic, biochemical, and physiological functions are influenced by hormones. So hormone deficiency will lead to not only premature aging, but more diseases. Okay, one good example is testosterone deficiency, which leads to many complications, including fractures. So these multiple hormones, I emphasize again, it's just not estrogen and progesterone, play a symphony. So youthfulness and good health are the result of this interplay of hormones. So we need to actually balance or correct the deficiencies, and also pay attention to excesses as we age. One of the hormones that's usually rises as we age is insulin. Please also check insulin always. And the other is could be estrogen, the xenoestrogens. So we need to also understand that our hormones peak at about 25 years, and then there is progressive decline. So the question we should be asking is, why not start bioidentical hormone replacement therapy early when there are already symptoms? And why not replace all the other hormones as well? Now, a very important point to realize is this: women spend at this current age and time, women, including adolescent and adult women, are spending more years with excess xenoestrogen. And generally, if you look at the clinical practice, women have a decline in progesterone first before estrogen. So in my clinic, I always emphasize women to correct their progesterone, increase their progesterone levels from the age of 40, which is very protective against breast, uterine, and ovarian tumors and cancers. How would you recognize those who need progesterone earlier than menopause? Would be those women who spend many years having dysmenorrhea, menorrhagia, and premenstrual syndromes, all point to estrogen excess. The average age for menopause, 50 to 55. So if you assume a woman lives up to 70 or 80 years old, from the time she reaches menopause, she's going to spend 2-3 decades of her life in the menopausal state. That means hormone deficiency state. So it's very important to realize this. So hormone corrections would be very critical if you want to give them a quality and quantity of life. But if a woman has delayed menopause after the age of 55, please watch out for the risk of gynecological cancers. What decides the age of menopause and the quality after menopause is that how you start your life. So I always emphasize this point. It is very important what happens before pregnancy and during pregnancy. So a healthy fetus will be a healthy child and healthy adolescent and healthy adult, and that's how we should age. But of course, all other factors in life is important as we age as well, because things like diet and other lifestyle factors, exercise, sleep, stress management, everything matters. It's just not hormones. So what I'm trying to say is that have a very holistic approach when you address such problems. So aging starts at conception and health at preconception. So how fast you age, what diseases you are predisposed to, also determined by the preconception health. So if we have an opportunity, please advise women to be healthy before they conceive. Menopause, we can divide into, we can say, okay, there is spontaneous menopause between the age of 50 to 55 or 48 to 52, it's around there, or you can have pseudo-menopause. This is when you can have what you call when the ovaries are removed. Now, please understand a very important point here. After hysterectomy, the likelihood of a woman losing 50% of her hormones, ovarian hormones, is a real possibility. So this is a reason why you should pay attention to women who have taken out their uterus. Even if they don't have the symptoms, if they have borderline deficiencies, then the hormone deficiency should be corrected. If you remove ovary, say for example, a woman presents to you with the endometriotic cyst of one ovary, so an oophorectomy was done. Now we should always assume that the opposite ovary would also likely to be diseased or less healthy, may not be an endometriotic cyst yet. So the function in terms of hormone production could be also compromised. So you also need to address this issue, test their levels and correct the deficiencies. But of course, women can also have premature menopause. Now, it's not unusual to see women who attain menopause at 45. So that's considered premature menopause. So the earlier a woman has lost the uterus and ovaries or premature menopause, the longer she's going to spend her life in a hormone deficiency state. So that's going to affect the quality and the quantity of life. And I mentioned this, that progesterone replacement is often needed earlier. In my practice, what I do is I don't give estrogen to every menopausal woman. I give it to them if there is evidence of a severe deficiency from the blood results. Otherwise, I use progesterone. I wait for the clinical symptoms like dry vagina, hot flushes, and sweats, because now we often see women who have excess estrogen, not from the ovarian production, but from xenoestrogens, as I mentioned. So you need to have progesterone in first, and then you can add the estrogen later. And progesterone is always a must with estrogen. Unfortunately, there are doctors who still use the synthetic hormone replacement therapy, and I've seen women even this date are taking Primaril, which is a synthetic estrogen, without progesterone. That's a very dangerous thing to do. And as I mentioned, adrenal and thyroid hormones will be required much earlier in most patients. So hormone declines from the age of 25 to 30, all hormones decline. However, insulin and xenoestrogens increase is common. So xenoestrogens can also cause premature menarche. So nowadays you often see girls by 9-10 years having menses. They can cause benign and malignant tumors of the breast, ovaries, and uterus. Problems persist even after menopause. So would you give estrogen? I mentioned to you just now that in my clinic, it's my preference to give progesterone first, and I wait for symptoms to be there before I replace the estrogen. Now, xenoestrogens, you should know, very easy to load yourself with xenoestrogens. If you consume a lot of chicken and meat, unless they are organically farmed, dairy products are full of estrogen. Use of plastics, you are at a higher risk. Deep fried food, chemicals, pesticides, excessive coffee, excessive alcohol, all these can add to the burden. Of course, I encourage my patients not to consume too much of soya or soy drinks because they also have estrogens. Now, premature menopause, you should identify the risk early. So if you have an opportunity to identify the risk, then you should warn these patients. Now, children born vaginally, that means mothers who deliver normally, their children have less risk of premature menopause. Breastfed babies have less risk of premature menopause. Vaccinations have been always questioned. It is possible that they can cause premature menopause, and the risk of premature menopause is also depends on whether your diet is healthy, whether you exercise, you sleep well, whether you have sun exposure, especially for vitamin D and the early morning sun, which is actually the near infrared, and whether you have nutrient deficiencies, especially some of the B vitamins and magnesium, whether you are loaded with endogenous and exogenous toxins, whether you have electromagnetic frequency exposure, all these matters. If you have a woman who's exposed to all these risks, then it's good to inform them that they can anticipate premature menopause, at which point in time, correcting the rest of the hormones would become mandatory. So premature menopause can also be caused by loss of deranged circadian rhythm. This is a huge problem now even among the youngsters because of sleeping late and using handphones and gadgets like laptops and iPads, because of the blue light that disturbs the circadian rhythm as well as the secretion of melatonin during the night, and the adrenal hormones, cortisol and DHEA in the morning. So your body just goes out of sync. It doesn't recognize the day and night because it has specific functions during sunrise when it is bright and specific functions after sunset. This is the circadian rhythm, but now it is deranged and disturbed in many because of our lifestyle, and people eat very late and including supper. So this is detrimental to health. So do premature menopause occur with increase with vaccinations? We don't have all the answers, but in my clinic, what I've seen is that because the current vaccinations, I see women who have got into amenorrhea, or women who have prolonged menses. I've seen girls with sudden onset of ovarian cysts. So there are problems. There are problems, but whether it will lead to premature menopause, we are not sure, but please keep it in mind. Spontaneous menopause can be too early or too late, as I've mentioned. Both have their risk. Too early, you're going to spend more time with hormone deficiencies. Too late, you have higher risk of cancers. Menopause, as I mentioned, you can have a hysterectomy if necessary, and then you will be menopausal women, or hysterectomy with bilateral oophorectomy, which means is 50 to 100% loss of testosterone, estrogen, and progesterone. Please remember that after hysterectomy, even with the ovaries left behind, women can have a loss of at least 50% of ovarian hormones. Very often, if you see women after hysterectomy, they feel tired, they have lethargy, they gain weight, they get diabetes, and they have more fractures. All this is because of hormonal depletion. So this is a case I saw, a very interesting case. If you look at post-hysterectomy, her testosterone was deficient. So you can actually have a prolapse. It's not uterovaginal prolapse, it's vault prolapse. So they still see the gynecologist. And she had coronary atherosclerosis, so she saw a cardiologist. She had an umbilical hernia, she saw a physician surgeon, and she was constantly tired, so she was seeing a physician. All this is because of testosterone deficiency. Okay. So hormone deficiencies, please remember, can cause premature aging, which itself is a disease, and other diseases. So other diseases can be fractures, can be disc prolapse, can be diabetes, can be heart disease, can be depression, and a host of other problems. So there is increased risk of obesity, diabetes, heart diseases, osteoporosis, fractures, disc prolapse, uterine, bladder, and rectal prolapse. These are some. There are many other symptoms or signs and symptoms of hormone deficiencies. So life will not be good and healthy, and women will not be happy and cheerful if hormone deficiencies are not correct. And please remember, correct all hormone deficiencies. Now, there is a difference between conventional or allopathic medicine and what we do in functional or integrative medicine. In allopathic medicine, you will hardly ever hear about replacement of testosterone, thyroid, or cortisol and DHA deficiencies. It's only about estrogen and progesterone. Synthetic hormones are used. Remember, synthetic hormones are not natural to your body. So it is difficult for the body to metabolize and use it without side effects, and also excrete the metabolites. So poor excretion of metabolites and detoxification will lead to cumulative toxicity. But there are many evidence to show that the synthetic hormones are detrimental to health. But the problem is, most of us, once we have qualified, we are not we don't continue to read and get into scientific studies ourselves. So we rely on medical sales reps for our information. Whereas in integrative medicine, you should think of you as a healer. That's your primary role. So I always emphasize this. Address the root cause of a problem. So you address the root cause to treat a disease and reverse the disease. The same understanding will also help you to prevent diseases. Deficiency of drugs are not the reason for diseases, and the body never asks for these drugs. It is only crying for help, and healing is only possible with natural solutions. Drugs are okay for emergency use. This is my opinion, and I'm sure all the doctors who are functional medicine doctors will agree to this. So we should primarily be healers, because that's what the patient comes to you for. So you correct estrogen and progesterone using natural hormones plus all other deficiencies, and all pillars of health must be emphasized. You consider nutraceuticals as well, and you consider the immune detoxification and antioxidant systems as well to give them a holistic healthcare. So this is a very important point. In integrative or functional medicine, we correct borderline or subclinical deficiencies. What does it mean? Now, you should aim hormone levels to about a 30-year-old. That means you do not accept age-corrected reference range. So because reference range given is adjusted to your age, you should actually aim for a 30-year-old. And aim for 25th centile. That means about 75% of the upper limit for most hormones. And this, if you consider and understand, then this is borderline deficiency. That means when you understand that there are women who spend many years of their life having signs and symptoms, they are still within the reference range. So as clinicians, we are supposed to treat the patients, not only the medical lab results. So when you understand and recognize the borderline deficiencies, you should only use natural or bioidentical hormones, and then you can be very preventive, precise, and you can offer personalized care. Now, if you look at this, what actually is that by the time the doctors are trained to recognize hormone deficiencies, they are already in the irreversible clinical stage. That means they are already having diseases. Okay. Now, the best way to prevent diseases and to treat or reverse would be for you to pick it up early from the blood test and then all the metabolites before it affects the enzyme activity and before it becomes a functional problem. So, optimum medical care, that means functional medicine, you start replacing hormones here because majority will already show signs and symptoms. Whereas conventional medicine will only tell you to start here when they are already in late stage of clinical disease. So why bioidentical hormones is because they have the same clinical structure as our hormones, they replicate the function of natural hormones, they are used as the natural hormones in the way they are metabolized and excreted. So there is no cumulative toxicity and they are safe for long-term use, provided you understand how to recognize the borderline hormone deficiencies. Now, the common bioidentical hormones are thyroid hormones, estrogens, progesterone, testosterone, hydrocortisone, dehydroepiandrosterone, and pregnenolone. Pregnenolone is considered as the mother of all hormones because all other steroidal hormones are the downstream effects or products of pregnenolone, which again comes from which becomes progesterone and then the downstream hormones. So the common hormone deficiencies are these, as I mentioned, thyroid, adrenal hormones, estrogen and progesterone, testosterone. We can be very deficient in growth hormone and melatonin as well. One could be deficient in vasopressin, oxytocin, MSH. I usually do not test, but if I see fine wrinkles, premature fine wrinkles, I correct the vasopressin. But always remember, estradiol, xenoestrogens, and insulin can be excess. So the thyroid hormones, what do? They act not only as a metabolic hormone, they act as an antioxidant. Now, before I go to the hormones, let me clarify what I meant by borderline deficiencies. Now, if you look at the reference range, this is important. Say, for example, in the laboratory here, the free thyroxine is 9 to 25. So, we doctors are trained to accept anyone within the range as normal. We do not treat even if they show the classical signs and symptoms of hormone deficiency. Now, that is wrong because 95% of patients will be within the reference range. Only 2.5% below and 2.5% above. If we are going to correct deficiencies only after they are below the reference range, in my clinical practice, for example, when I take thyroid, these patients who are below the reference range are only seen in very acutely ill ICU patients or in cancer patients. So the fact is 95% are within the reference range. So what we should do is to take 75% of the upper limit, anything less considered that as deficient. This is what we label as borderline or subclinical hormone deficiencies. And this is when you should treat. So thyroid hormones, as the master of orchestra, it has many functions. But what we know now is that thyroid hormones also act as an antioxidant. They can reduce intracellular oxidative stress, and one of the most critical hormones, but sadly underdiagnosed and undertreated. So intracellular oxidative stress is a huge problem. It increases reverse T3. That means Your T3, which is the metabolically active hormone, reverse T3 is the opposite because it's metabolically inactive. So it can be caused by excess iron and calcium and copper. These are three supplements I tell patients do not take unless you have proven deficiency. No routine calcium, iron and copper supplements. So if you want to measure the level of intracellular oxidative stress, you can measure intracellular T3, which is not routinely available. Thyroid hormones actually also help you to localize the focal infections. So they also help in sepsis, they decrease all-cause mortality. Discontinuing thyroid hormone replacement increases mortality. So please pay attention to thyroid hormones as well. As I mentioned, it's not just about estrogen, progesterone. By the time a woman reaches menopause, more than 90% will be hypothyroid. So these are the signs. I'll go through the signs and symptoms quickly. The most common ones will be cold intolerance and morning stiffness and lethargy. So they have to be physically active to feel energetic. If they sit down and they feel tired and sleep. So they can have depression, memory loss, face will look puffy and sallow look, the anemic look, puffy eyelids, and they can also have loss of eyebrows, outer third. Thyroid hormone deficiency is associated with enlarged thyroids, could be because of cysts or adenoma. You can have dry skin, keratosis, palms can be cold and yellow. There can be hyperlaxity, brittle nails, carpal tunnel syndrome. This is unrecognized as the cause. So this is how yellowish palm looks like because of, excess keratin deposition, keratinoids. And this is a lady I saw in pregnancy. She already had a surgery on the left hand for carpal tunnel syndrome. She had recurrence during pregnancy. Replacing thyroid hormones cured her problems without having to have a surgery. So please remember, carpal tunnel syndrome or numbness and tingling in the fingers, look for low thyroid hormones. Hypothyroidism can also lead to constipation and bloating because everything is slow, including your bowel motility. You can have low hydrochloric acid. You can have thick swollen calves. You can have cold and dry feet, cracked skin under on the feet, and also flat feet. Look for flat feet in children to diagnose early onset hypothyroidism. This is how keratosis and cracked feet look like. You can have diffuse hair loss. You can have kyphosis. So this is how diffuse hair loss looks like. Now, very often we don't recognize kyphosis or scoliosis as thyroid hormone deficiency. As I mentioned, everything can be slow and everything can be lax. So that's why children have wobbly gait because the knees joints will be lax. And that's the reason why they also have kyphosis or scoliosis, because of laxity. Now, progesterone is the other hormone you should always consider. It declines earlier than the estrogen. Please remember this. By menopause, there's already 75% decline. Women with PMS, fibroids, ovarian cysts have high estrogens, estrogens, as I mentioned, and they often start their life with low progesterone much before menopause. So in my practice, I usually advise them to replace or increase progesterone levels after the age of 40, unless they have problems of PMS, fibroids, ovarian cysts. It's when I start them on progesterone. So what are the signs of progesterone deficiency? It's the same as estrogen excess. So you can have enlarged tender breast, you can have fibroadenosis, fibroadenoma. Remember, fibroadenosis and fibroadenoma are reversible when you optimize progesterone. As I mentioned, fibroids, adenomyosis, endometrial hyperplasia, and polyps. as well as benign endometriotic cysts of the ovaries. And estrogen excess can cause malignancies in this. Progesterone deficiency can also lead to early menarche because of estrogen excess. So you have PMS, menorrhagia, dysmenorrhea, frequency and tenesmus during menstruation, which is a sign of endometriosis. So these are signs of progesterone deficiency, which is equivalent to estrogen excess. So the treatment is progesterone. So during pregnancy, progesterone deficiency can lead to threatened or spontaneous abortions, nausea, vomiting, remember premature labor, also caused by hypothyroidism, early onset of Braxton Hicks contraction, also caused by magnesium deficiency, postnatal depression. And postnatal depression can also be caused by cortisol deficiency. The treatment is to use oral micronized progesterone, which comes as 100 milligrams caplets, or natural progesterone cream. Usually the dose is again 100 milligrams, applied once a day, preferably at night to give you better sleep. And you can also use compounded progesterone cream. The dose is still the same, 100 milligrams a day, or more, as the case tells you. Now, estrogen deficiency, by and large, is not so is not seen earlier than progesterone, but you should watch. So usually there will be post-menstrual staining, short cycles, and scanty menstrual flow. Now, this is associated with hypothyroidism as well. Please remember this. Women can have small breasts and diffuse hair loss, dry vagina, loss of libido, hot flushes and sweats. All of you all know this. There can be thin vertical lines on the lips, and also increased risk of osteoporosis, cardiovascular diseases, Alzheimer's, memory loss, etc. The classical signs will be hot flushes, sweats, dry vagina. Estrogen excess, as I mentioned, is similar to progesterone deficiency. So you can have, say, PMS, menorrhagia, fibroids, endometriosis, fibroadenosis, adenoma of the breast, mastalgia, cancers in the uterus, ovaries, and breast. Women can be anxious, irritable, with mood swings, and early menarche. So the signs are similar, and the treatment is still progesterone replacement. Of course, you can have natural means to detoxify and eliminate the excess, like you can have indole 3-carbinol or DIM. Now, androgens in women not often talked about, but is as important as progesterone and also estrogen. They come from adrenals, ovaries, and peripheral tissues. Testosterone is mostly from ovaries. DHA is mostly from adrenals. So quantitatively, actually, women produce more androgens than estrogen. So in descending order of serum concentration, you have androstenedione, testosterone, dihydrotestosterone, and DHEA. We focus usually on testosterone and DHEA. So testosterone deficiency, let's talk about testosterone deficiency. You can have testosterone deficiency once a woman has reached menopausal stage, or after hysterectomy and hysterectomy with bilateral salpingo-oophorectomy. Remember, I've mentioned, recognize the deficiencies in hysterectomized women, even if they have the ovaries. Chronic stress, adrenal insufficiency, Addison's disease, synthetic corticosteroids therapy. Now, when this applies to young women, when they take contraceptive pills, you can have suppression of ovarian hormones. Then you are creating testosterone deficiency. Please remember this. Contraceptive pills also suppress adrenal hormones. Can be because of chronic illnesses. Statins decrease testosterone and all other steroidal hormones. So to me, this is cruel treatment, and there are other natural treatments which are very effective to bring down cholesterol if they are very high, and also treat fatty liver. But statins not only decrease the steroidal hormones, testosterone, estrogen, progesterone, cortisol, and DHA, they also reduce the level of vitamin D, because vitamin D is also made from cholesterol. Another example would be Q10. So by reducing all these, who on earth can tell you that the people who are on statins will enjoy better quality of life? In my opinion, it is very difficult to justify when you consider these points. Can be seen before from puberty, especially if you see girls with very poorly developed muscle, underdeveloped sexual drive. They can be anxious, fearful, and with excessive emotions. And these girls can have low self-esteem. So it's good to recognize, not common. Usually testosterone deficiency is associated with anemia and pallor, loss of muscle mass, increase in fat mass, kyphosis, and loss of height because of vertebral collapse. There will be more fat on the breast, abdomen, and hips, flabby abdomen and cellulite, dry eyes, fine wrinkles above the lips and corner of the eyes, decreased axillary and pubic hair. What is more common would be fat deposition, energy. This is very common. So anyone, including men, with testosterone deficiency, they have lethargy and they have reduced physical capacity. In addition, they also recover poorly from physical exercise. So if they go and exercise today, they feel tired for 2-3 days. Typical of testosterone deficiency. As well as loss of libido, varicose veins, reduced clitoral and nipple sensitivity, low resistance to stress, depression. So the more common ones will be loss of muscles, increase in fat mass, low energy and reduced physical capacity, and slow recovery from physical exertion, and low libido. After that, of course, you have more medical complications like chronic congestive heart failure, insulin resistance. So in order to reverse diabetes, testosterone becomes one of the prominent treatment or main pillar of treatment. Congestive cardiac failure is easy to understand because the heart is a muscle. You need testosterone to keep the muscles pumping. So you can also have decreased HDL. The skin can be thin and dry hair, sagging cheeks, and thin lips. Pelvic organ prolapse is common with testosterone deficiency. Again, the muscle strength depends on testosterone, which is the king of the hormones. So pelvic muscle weakness will lead to prolapse of the uterus, ovaries, and the rectum. But of course, there are many other things that are blamed, like multiple pregnancies. But you look at natives who have many pregnancies, they don't suffer from this. Now, very important point to remember is testosterone deficiency is associated with increased risk of diabetes. And there are many reasons for this, but replacing testosterone will even improve the glucose tolerance levels, improve the blood sugar, improves the insulin, as well as HbA1c. When all these are improved, of course, you will have reduced diabetic-related complications and mortality. Okay. So testosterone deficiency is a serious health issue in women who have premature menopause, after hysterectomy and oophorectomy, or after menopause. So if you replace, and of course you notice that increased sexual interest, increased sense of emotional well-being, they'll have a lot more strength and improves physical performance. If, like men who go to the gym to work out, if you cannot build muscle mass, then you are likely to be testosterone deficient. It also helps the skin from sagging. Bone health is absolutely critical, and it depends to a large extent on testosterone besides estrogen. And you feel happy because it's also the focus and attention. Testosterone deficiency takes away the determination. So you are not a very determined person. You usually procrastinate on decisions because it actually improves brain health. So I tell my patients, brain, bones, muscle, and heart health. The king of the hormones is testosterone. So you can use transdermal, rotate the sites with gels or creams. Usually it should be applied on the inner thighs. In order for testosterone to work well, estradiol must also be optimized. But as I mentioned, I'm a little bit cautious. If women have spent a lot of time, many years with PMS or heavy painful menses, or those who have had fibroids and ovarian cysts, I always replace progesterone first. Excess can cause salt and sugar cravings. They can be aggressive, angry, and irritable. You can have increased facial hair and acne. Watch out for the growth of hair on the lips, moustache, as well as the beard. That is not a side effect, it is just excess. So you need to stop, wait for these problems to settle, and you can halve the dose. Excess can also cause scalp hair loss. So these are things that you tell the patients to come back to you if they have these problems. Now, hormone replacement with bioidentical hormones is absolutely safe when used to treat not only severe deficiencies but also subclinical deficiencies, but must be used in physiological doses. So the dose for women, testosterone dose for women is 1/10 of men. So men, if they use 100 to 150 milligrams a day, women will usually require 10 to 15 milligrams a day, usually 10 milligrams. But if you notice, tell the patients, if they have increased facial hair or acne or loss of scalp hair, or if they have hoarseness of the voice, please come back, stop and come and report to you. If you give this information, informed consent, mentioning all these things, then you're unlikely to get into any kind of trouble because you have already warned the patient. Now, cortisol deficiency, usually the patients can be thin, they are nervous and irritable, you can have acute hair loss, you can have alopecia areata, thin and hollow face, these are very common, brown spots, dark circles under the eyes, wet palms when they are nervous. So usually the typical signs would be someone who's anxious, nervous, and irritable. They can have wet palms, always on the edge. They are not relaxed. They are not the calm and happy people. Very, very common nowadays to see such people, especially their symptoms in the morning, including adolescents and adults. So these are all the signs of cortisol deficiency. Hollow face, you can have inflamed or darkness below the eyes because allergies are more common. Cortisol deficiency needs to be recognized because if you do not correct cortisol deficiency, you'll notice that the patients are always anxious and they are not settled. So they may not even realize the benefits of other hormones that you replace. And with cortisol deficiency, sleep will certainly be affected. Even melatonin may not work. The dose is usually 10 milligrams in the morning and 5 milligrams 4 to 6 hours later. But the first dose in the morning could be higher, 20 milligrams, 15 to 20 milligrams as well. If it is needed, someone who doesn't settle down with 10 milligrams, you can slowly increase. But very important to focus on the adrenal gland health. Sleep early, avoid sugar, vitamin C, vitamin D, and magnesium at optimum doses are usually very necessary for cortisol secretion and activation. And avoid or reduce exposure to blue light, as I've mentioned. Meditating in the morning is absolutely important to maintain adrenal health. One other beautiful things that all of you all can do is to go out in the sun, early morning sun, before 9 a.m., expose yourself and grounding. That means stand barefooted on soil or grass. That will actually reset your circadian rhythm and improve your adrenal. Besides cortisol, you also have DHA deficiency. It does more than 150 functions in the body, and it can be a reservoir for other hormones like estrogen. And DHA is a strong booster of immune system. When you have cortisol deficiency, almost always you have DHA deficiency. The only time I do not treat in a DHA deficiency if a woman already is hirsued, or I'll use half the dose. The standard dose of DHA replacement for women would be 15 milligrams. If they are obese, they can take 25 milligrams. Deficiency can cause infertility, allergies. DHA deficiency is extremely common in patients with autoimmune diseases. Can cause anxiety, tinnitus, and noise intolerance. It's a good clue. Of course, men also can get easily sunburned, dry eyes and skin, poor muscle tone, that's not very common, reduced axillary and pubic hair when DHA is deficient significantly over a prolonged period of time. Growth hormone is another hormone that can be deficient. Remember, intake of sugar, which is so common, suppresses growth hormone. Sleeping late, you will not produce. Exposure to blue light at night, you will not produce growth hormones in sufficient amounts. And this is a hormone that actually improves muscle mass and gives you a sense of inner peace and wellness. Otherwise, you have premature aging. All the signs of premature aging like wrinkles and sagging, that means that there is also premature aging of the organs. So it's a hormone that actually addresses premature aging and can help to reverse aging. You can see the difference within 3 to 6 months. These are some of the signs of growth hormone deficiency. Thin lips, sagging, and excessive striae. This can also be caused by cortisol deficiency, vitamin C and zinc deficiency, less collagen. Now, melatonin is another hormone. Please do not ignore, because this is the sleep hormone, can only be produced if you sleep in darkness, if you are exposed to sun in the daytime, or if you have sufficient levels of vitamin D with balanced cortisol in the morning. It comes from pineal gland, also from the GIT and retina. A very important point to remember is that the early morning sun, when it touches the retina, it helps actually to produce local melatonin. But melatonin can also be produced in and around your mitochondria, not for sleep. During the daytime, when you are exposed to the near infrared, that's the early morning sun. Regulate circadian rhythm, as I've mentioned. Strong antioxidant increases growth hormone levels. It's anti-inflammatory and a very strong immune booster. There are studies done, I think, from Philippines. Only melatonin was used to treat COVID patients, and the improvement was significant. So there are a lot of benefits of melatonin and immune system, especially now during the pandemic and post-pandemic, and they still keep bombarding us with more and more fear and threats of monkeypox and whatever variants actually, because they shouldn't mean anything to you if your immune system is strong. So they activate the T helper cells, stimulates the natural killer cells, macrophages and monocytes. Melatonin is a powerful anti-carcinogenic hormone, and it also helps to avoid the nocturnal hypertension. Remember the antioxidant function of melatonin. You can increase this in all your cells in the morning with just sun exposure. Of course, it has many other benefits, like it decreases the risk of stroke, cardiac muscle injury after a myocardial infarct, improves cardiodynamics, reduces LDL and increases HDL. It's neuroprotective, has metabolic benefits for bone health, for reducing the risk of obesity, improves mood and cognition, improves reproductive health. But please focus on sleep, its ability to work as an antioxidant and a strong immune booster. So it helps you to fight viruses, bacteria, fungus, and cancer cells. And it also reduces the risk of nocturnal hypertension. These are the classical benefits of melatonin. It crosses blood-brain barrier, so you need to know that it is very neuroprotective. Alzheimer's is getting very common. It's known also as type 3 diabetes because of high carbohydrate consumption. This is just to mention that, actually melatonin can decrease obesity by reducing stress and sleep deprivation, because in sleep deprivation there is binge eating and there is also emotional eating. Anytime you are depressed, you eat, and especially that becomes the carbohydrate. So correct other hormones as well, aldosterone and vasopressin. How do you diagnose aldosterone? You can have someone with postural hypotension. They are okay when they lie down. When they have hypotension when they stand up, they are not able to hold much urine, so they have diuresis. And they actually can lose salt and water. So they have dry skin, wrinkles, whereas vasopressin is the hormone that holds water, so it reduces the risk of dry skin and fine wrinkles. Vasopressin is also known as the memory hormone. So there are times that I've advised students to take vasopressin just before their exams, because this is a hormone that actually helps you to log in the imprint. So this is very useful for short-term memory, not long-term. So in summary, hormones work in synergy. Excess or deficiency of one hormone will affect the actions of other hormones. So always look at them as a family. Correcting one hormone is not the best solution. The best holistic or functional way of addressing hormone is to address all the hormone deficiencies, but do address hormone excesses, especially insulin, which is very detrimental to health. I tell my patients high insulin is like having 8 inside diseases, including pre-diabetes and becoming a diabetic, premature aging, increased risk of cancers, increased risk of infections, suppressed immune system, obesity, and Parkinson's, Alzheimer's, and the list is very good. So I always check insulin in my patients. Always use bioidentical or compounded hormones, and it has to be in physiological doses. So the doses are different for men and women, but very, very important is that you please understand that in order to practice medicine effectively as a healer, as a doctor, as far as hormone treatment is concerned, is to recognize the fact that 95% of your patients will be within the reference range and yet have a lot of signs and symptoms of hormone deficiencies. Now, as clinicians, we are supposed to address the issues that the patients are concerned with. If you rely only on laboratory testing, then you will undertreat majority of these patients. That is not just. Okay. Number two, the reference range is obtained from all the blood samples that are sent to the lab, and they take an average. And that's not necessarily from healthy people. I'm sure you know what I'm saying. Most of the blood tests is done in people who have medical problems. Obviously, you don't find healthy levels. And the third disadvantage of that is when you receive a result, it is adjusted for age. That means at 60 years, we accept, for example, a testosterone level should be much lower than a 30-year-old. But a 30-year-old is the one who has robust health. A 60-year-old, if he suffers from testosterone deficiency, they have all the classical signs and symptoms. Why would you want to accept that the testosterone deficiency at a 60-year-old is normal, even though you know that testosterone deficiency causes risks like fractures and heart disease and obesity and diabetes and depression and so on? That is not good medical practice. That is conventional medicine. In functional medicine, what we are trying to tell you is the first thing to remember is that you help the patients to live healthier and extend their lifespan by preventing diseases, helping them to reverse the diseases without having to depend on drugs unless there is an emergency. And hormones play a very critical role in this. Okay, thank you very much.
Thank you very much, Dr. Selvam. Please give applause to Dr. Selvam. So thank you for very knowledgeable and interesting talks. So after hearing your lecture, Dr. Selvam, I feel I suffered from many hormones deficiencies. So I think I need to start the therapy soon. Okay, ladies and gentlemen, now we come to Q&A sessions. There will be 2 sessions, and each session is for 3 questions. Don't forget to mention your name and your institutions. Please, any questions from floor? Actually, I highlighted many issues from your lecture, Dr. Selvam's, including the most interesting for me is medical care is an industry, huge industry. So we cannot cope with the industry with the only conventional medicine. So we need to find the new pathway to treat the patient holistically. Dr. Selvam.
Yes, so, exactly.
Yeah, Dr. Selvam, one of our participants sent me questions in Bahasa Indonesia. I will translate to you. So in premenopause women, there will be a decreasing of many hormones. So which ones should be the top priorities to be treated, the hormones?
In premenopausal women,
yes,
the common deficiencies would be thyroid hormone, as well as the current lifestyle and the stress that everybody is exposed to. Cortisol deficiency will also be common. So I will focus on cortisol. When I replace cortisol, you have to replace the DHA as well, because just replacing cortisol alone will suppress the DHA because of the feedback system. So these 3 would be important, but I always emphasize, as I mentioned, irrespective of the age, if I see a patient who has presented to me all the signs and symptoms of estrogen excess and progesterone deficiency, like what I mentioned, excess menstrual flow or painful period of premenstrual syndrome, those who have had ovarian cysts and fibroids, these are all signs of progesterone deficiency which can come in much before actual menopause. So these are the hormones that I will treat. Growth hormone, of course, is expensive, not everybody can afford, but focus on these hormones. And as the age goes by, please remember, it's not just estrogen and progesterone. Testosterone deficiency is always together because they all come from the ovaries. Very much undertreated. Testosterone deficiency is underdiagnosed and undertreated.
Okay, thank you, Dr. Selvam. Any more questions, please, madam? Please mention your name.
Selamat pagi, saya mungkin akan mengajukan pertanyaan dalam bahasa saja ya dok. Oke, nama saya Melisa dari Tangerang. Yang saya mau tanyakan, semua paparan dari Dokter Selvam tadi mengenai defisiensi hormonal. Nah, yang saya mau tanyakan adalah kita tidak mungkin menunggu gejala saat memeriksa atau menterapi pasien. Jadi ada advice gitu dari Dokter Selvam kapan dimulai kita harus mulai notice gitu sama defisiensi ini. Jadi sebelum terjadi defisiensi, preventifnya kita tuh dimulai dari usia berapa kita sudah mulai harus memeriksakan semua gitu, atau kita sudah mulai harus ada suplementasi apa yang harus kita berikan, baik buat kita sendiri, misalnya kerabat-kerabat kita, ataupun kita bisa mengedukasi ke pasien kan, dimulai dari usia sekian kita sudah harus mulai mengkonsumsi ini dan memeriksakan ini. Ya, itu saja dokter, terima kasih.
Thank you, Dr. Melissa. I think you can understand that because you speak Malay, Dr. Selvam.
Yeah, can you translate some?
Okay, I will translate
Please,
you some. So we don't need to wait for the symptoms of hormones deficiency. So when the exact time for us to know the early hormones deficiency symptoms, and then what should we do before the symptoms goes worse.
Okay, so that's why I mentioned and I explained again. I ended my lecture also explaining about recognizing these borderline deficiencies. So if you have a patient who has results within the reference range, just do not accept unless the result is about 75% of the upper limit. Then that is optimum health. Anything less, that patient is deficient. But of course, you have to go back to the patient and ask her whether she has signs and symptoms, elicit those things. If this correlates with clinical presentation, then you should treat the patient. And I also mentioned that not all the hormones need to be treated early. Thyroid hormone deficiency starts very early in life. I see many children having hypothyroidism. So that is one hormone probably will be the first hormone to be replaced, followed by with the current lifestyle and stress and excess sugar, lack of vitamin D and vitamin C. That would be very important for adrenal health. So I see a lot of women having cortisol and DHA deficiency, and I do not hesitate to replace these hormones even in pregnancy. Remember, even in pregnancy and breastfeeding. So that's the order I look at it. And if once they have had a hysterectomy, even at the age of 35 or 40, I always look for testosterone deficiency. And I mentioned when I have patients with fibroids or ovarian cysts and fibroadenomas, I will explain to them that these are caused by progesterone deficiency and estrogen excess. I explain to them all the sources of xenoestrogens and how to replace the progesterone. This is how I approach my patients. But of course, all this must be explained. You must explain to them the signs of deficiencies, what happens when you replace the hormones, if the dose is high, what are the symptoms they experience, and they should come back to you. This explanation must be given and take an informed consent. Now, for example, I give you one example. And just now when one of the doctor's colleague was asking a question, I see many of you all are still wearing masks. It could be mandatory in Indonesia, I'm not very sure. But remember, the immune system is so powerful that if you have a strong and effective immune system, it will kill all viruses. And what kills all the viruses will be vitamin C, which human body does not produce. So just as you focus on vitamins and minerals, you need to have a very balanced, optimum level of hormones for you to live healthy and long. Okay.
Okay, Dr. Selvam, thank you. So we don't have any specific age yet to start the hormone replacement therapy.
No, even if you have an adolescent with hypothyroidism,
okay,
you should start. because the symptoms and signs of hypothyroidism are so clear and classical, and you can have evidence by testing the lab, doing lab testing. The only thing is you'll be caught by the reference range if you are not able to grasp what I'm saying. The level of most hormones should be at about 75%, 80% of the upper limit. Say, for example, if you take free T4, the reference range the lab gives you is 9 to 25. This range is very wide. What is the optimum range level? It's about 75% of the 25. So what I see and what I'm telling you is by the time the patient approaches the lower range of 9, they are already very sick. So why would you want to wait when there is classical clinical presentation of hypothyroidism? So these are things to remember. So it doesn't matter at what age, and of course you don't replace testosterone or estrogen too early unless there is a definite indication. Most other hormones will be started early, including progesterone can be started early if there is an indication.
Okay. Thank you, Dr. Selvam. Dr. Melissa, I think the discussion answered your questions here. Thank you, Dr. Selvam. Because the time is up now, ladies and gentlemen, finally we come to the end of part of our presentation. We would like to say many thanks again to Dr. Selvam.
Dr. Iflan,
Yes?
sorry, I would like to introduce our new president, Dr. Selvam. Dr. Selvam, is Maya here? Hi.
Maju kak.
Over there.
Kak Maya maju kak di sini. Kakak di sini. Kakak.
Please, camera.
Di sini kak.
We would like to introduce our new chairman of Perdaweri.
Hi.
Kakak maju lihat sana.
Oh. Dr. Selvam, can you see me now?
Sorry.
Can you see us?
Oh, ininya. Oh.
Not only her.
Dr. Selvam, can you see us?
Yes, namaste.
Oh, namaste. Maya is here. I would like to introduce.
Selamat pagi.
Selamat pagi. I would like to introduce our new president, Professor Purnawan. So as Prof. Acha is already saying goodbye for the second time as a president-elect, we have our new one. So I would
Congratulations. Congratulations.
Yeah, nice to meet you. Yeah, Dr. Selvam.
Yes, me too.
Yeah, the president is always Prof. Acha. I'm the replacement.
Okay.
Okay. Well, continue. Thank you very much for your time.
Yeah.
And
Very
one
well
last-
organized. Thank you.
Yeah, one last question, Dr. Selvam. Actually, I would like
Yes.
to ask this. Since a long time ago, we always met in KL or
Okay.
wherever. What is actually your regimen for yourself? Because there are so many young, pretty, handsome doctors here that still relatively young, not of course our ages, yeah. So that maybe you can give tips or whatever you do for your supplementation or for your hormone replacement. Thank you.
I actually started my thyroid hormone replacement and DHA and hydrocortisone very early. I started this more about 25 years ago. But by the time I realized this, I was already late because I was quite sick. But of course, I didn't have the knowledge. There was not much of a training, and there were no local conferences. We have to go abroad to go and learn each conference time. By the time you go and come back, it costs a huge amount of money. But something told me, I just woke up one day and asked myself, I've been trying to treat simple problems from the time I was in medical school. And even by the time I became a specialist, the problem never went away. It was only getting worse. So I asked myself one question: what am I missing? The point that was clear to me was I was missing the root cause of the treatment disease, not the drugs, not the surgeries, though they are necessary in some situations. So that is when I addressed diet, then I added on nutritional therapy. Then I found that something else is still missing because there was no vitality, there was not much of energy. Then that's when I added hormones. But the first hormones I added was thyroid, followed by hydrocortisone, that is cortisol, and DHA. Then as I aged, I added testosterone, and growth hormone. Now, in order to protect the prostate, I do take a small dose of progesterone. I take 100 milligrams on alternate days. I take my aldosterone in the morning, and I take vasopressin at night. I don't take vasopressin every day. A lot of these hormones I prefer to take Monday to Friday and skip it on Saturday, Sunday. Not because it is scientifically not necessary, but I just want to make sure my body remembers to do what it has to do. I don't want to just shut off the endogenous mechanism.
Okay.
So I have this regime Monday to Friday, I skip 2 days. But I can give you one example of how powerful testosterone is for both men and women. I started working out in the gym only after the age of 50. Before that, I wasn't an exercising person. I started to jog, and then I've done some half marathons, and I stopped. After the age of 50, I went to the gym. So I always work out in the gym. But even today, like yesterday when I went to the gym, I could still do a deadlift of 130 kilos.
How old are you now?
Although I'm 60 plus, I can still do.
60 plus berapa?
Now, what
How old are you
determines
now, Dr. Selvam?
66.
Okay. I'm 69. Yeah. So
Oh,
yeah.
you look good for your age.
Yeah.
So the
So you
vitality,
periodically atau annually check your lab to see the result.
once a year will do. You don't have to repeat the hormones very often. Once you have a lab test done,
Okay.
most of the time you can actually assess clinically. Like for example,
Oh, okay.
if you give thyroid hormone, you don't have to repeat to see if it is optimal. If the patient feels warm enough, more energetic, and they sweat when they exercise, they lose weight, that's classical sign of
Yeah.
normalized
The
thyroid
symptom
function.
is the okay.
Yeah, so you can go by that, because otherwise this treatment would become very expensive for patients.
That's true. That's true. That's why I'm.
Yeah, so I
asking
don't
about-
keep
yeah.
repeating, but there are tests I'll repeat. Like for example, if homocysteine is high, insulin is high, or ESR is high, or CRP is high, I would like to repeat those tests to make sure I have managed my patients well. Hormones, for me, is mostly a clinical assessment. After the initial test, then you can do once a year.
Okay. Thank you. Thank you.
Thank you, Dr. Selvam. Thank you, Dr. Ivan.
Thank you, thank you,
okay.
Mr.
Thank
President.
you all the best,
Please
Dr.
give
Selvam.
applause.
Let us meet
Berikan tepuk
again.
tangan yang meriah untuk
Thank you.
Thank you, Dr.
Datuk
Selvam.
dan
Thank you.
moderator kita yang
Assalamualaikum
ganteng, Dr.
warahmatullahi wabarakatuh.
Ilva.